Cataract is still the leading cause of blindness worldwide, and we have come a long way since the early days of couching. To the time when Dr. Harold Ridley implanted the first intraocular lens. To the now modern-day Kelman's phacoemulsification. Visual rehabilitation after cataract surgery has also moved on from the use of aphakic glasses to modern-day intraocular lenses to provide spectacle freedom. This video presents some of the challenges faced with the use of intraocular lenses and provides a step-by-step guide to management. The first pearl is for careful intraocular lens inspection prior to inserting it into the eye. As illustrated in these two examples, there were defects in the leading haptic in the first instance and the trailing haptic in the second. One must be vigilant to spot these manufacturing defects before inserting the intraocular lens. The second pearl is to pay attention to the technique of IOL injection. As shown in this example here, a preloaded intraocular lens was inadvertently and prematurely released from its cartridge and ended up outside the eye. In the next example, the lens had not been appropriately loaded into the cartridge and subsequently was stuck. And after careful inspection and removal, it was noted that the haptic had fractured and completely broken off. It is therefore important to take proper care in loading of the intraocular lens. Be familiar with the lens platform which is being used and always do it yourself. Pearl number 3 focuses on intraocular lens explantation. And in this example, the intraocular lens was noted to be opacified after it had already been injected into the capsular bag. Always ensure there is good viscoelastic fill of the anterior chamber and the capsular bag before exteriorizing the IOL and cutting it for removal. A Pac-Man technique is used in this case where there is no need to transect the intraocular lens completely. In the following example of the explantation of a plate intraocular lens, where viscoelastic was first inserted into the capsular bag and the anterior chamber, and subsequently a bimanual technique was used to exteriorize one haptic followed by the other. Once the IOL is in the anterior chamber, it is rotated and orientated such that the haptics are facing the corneal incision to allow complete bisection of the IOL into two separate halves. These are then removed separately. The next pearl will focus on intraocular lens insertion in the presence of capsular compromise. Proficient as we are as phacoemulsification surgeons, we are bound to be faced with instances of capsular compromise or complications. During such times, the priority would be to safely remove all nuclear material, as well as to manage any vitreous that may present. Subsequently, the focus will be to the intraocular lens management options. If the anterior capsule is still intact, oftentimes we would insert a 3-piece intraocular lens into the sulcus and subsequently prolapse the optic beneath the anterior capsule to perform an optic capture. This technique allows good centration and stabilization of the intraocular lens. An alternative method would be to perform a reverse optic capture. In such a case, the anterior capsule will have to be relatively smaller than the optic of the IOL to allow the single-piece IOL to be first inserted into the anterior chamber and subsequently have the haptics tucked into the bag with the optic sitting above it. In this example illustrated here, a toric intraocular lens was first positioned in the correct alignment and subsequently positioned by reverse optic capture. The final pearl will focus on IOL fixation, and this will be instances where there is significant zonal compromise and insufficient capsular support. My go-to technique would be the double needle Yamane technique, which is a transconjunctival haptic fixation method. The conjunctiva is first marked 2 mm posterior to the limbus 180 degrees apart, and subsequently 2 thin-walled 30-gauge needles are inserted to exteriorize first the leading haptic of a 3-piece intraocular lens, followed by a trailing haptic as illustrated here. Low-heat cautery is then used to create flanges at the end of each haptic, which is then buried into the scleral tunnels. This technique in my hands has provided very central and stable haptic fixation of intraocular lens. Intraocular lens management is a vital component of cataract surgery. As cataract surgeons, we have to have a good set of techniques and tools in our armamentarium to successfully manage the intraocular lens, especially in tricky situations.